Hello everybody, my name is Mona. So today I'll be doing my clinical journal. So I'll be talking about a patient I met during the clinical encounter. So this patient is a 65-year-old gentleman that was brought from the nursing facility to the behavioral center where I was in my clinical rotation. Patient presented with aggression, violence, hearing voices, throwing things. Actually, the nursing home staff said he was throwing things, he was being violent to fellow residents, so they had to bring the patient to the behavioral center for him to be assessed. So at this point, it came to my knowledge that at some point I might be seeing aggressive patients. I might be seeing people like this. So it came to my understanding that some patients might have this borderline. They might be at the borderline or at the edge between mental health problems and medical problems. So this patient is a 65 years old gentleman, and one of the past medical history was dementia. So right now, because he actually presented with psychiatric symptoms, hearing voices, hallucinating, aggression. So at that point, it's difficult to draw a line between dementia and psychiatric problems. So that was one of the experiences I haven't experienced in the course of my practice. So this experience broadened my, I'm talking about the clinical impact and learning. This experience broadened my learning about elderly people, about looking out, caring for elderly people. This shows that elderly people can present with different signs, psychiatric symptoms that could mimic, that could look like medical problems, because in the medical hospital, like in the acute setting, we could also see patients that are confused like that, but they are delirious, like they are being treated for UTI. So in this condition right now, so all these things are like interwoven, all these things are like confusing. So it broadens my knowledge that psych is broadened, psych is like elaborate. I should be able to distinguish, I should be able to know that streamline, that marginal, that borderline between psychiatric problems and mental problems. Also, during this course of encounter, it's also broadened my knowledge about safety, patient safety, and making the best decision for the patient at that right time. For instance, during that scenario, we had to give some medications to help the patient calm down. So we gave something like benzodiazepine to help calm the patient down. Then after that, patient was put on medical one-to-one. So it broadened my knowledge on the use of chemical restraint, because at that point we were like, is this not chemical restraint? But no, it is not. When you use the minimal dosage of a drug for a therapeutic response or to calm a patient down, that is not being considered as a chemical restraint. So that was how we had to handle that situation. Then we had to start an observation chart to document the medical one-to-one sitter started documenting the patient's behavior every 1 hour. So it's also broadened my knowledge that we need to know the behavior. When patients present with this kind of symptoms, we need to monitor their behavior on a daily basis, on an hourly basis, which can which can direct our treatment plan, or can help us during the discharge process, or can also help us to know exactly what the behavior is all about. Talking about my strength during this clinical encounter is that I remained calm and composed irrespective of the tension, the patient came with, irrespective of the agitation, aggression, because one has to be calm to be able to, to be able to think out plans, to be able to help the patient. So there is no need to panic. There is no need to, there is no need to be also agitated and add to the agitation that is in the environment. So there is need to always calm down and maintain, be still, irrespective of patient signs and symptoms. The most I can do is, if patient becomes severely violent, to call the security for the patient, because most times when patients are very aggressive and you call the security for them, then when they come to talk to them, they're kind of calm, they're kind of settled. So that is also like a kind of safety plan towards the staff, towards me and other members of the staff. So, talking about the reflection and application for future MP. So, this clinical encounter, reflecting on this clinical encounter, I was able to know the relevance of chemical restraint, what a chemical restraint actually is in the real sense. Also, it broadens my knowledge about the role of the multidisciplinary teams, because during that time, during this clinical encounter, I also got the case manager involved, because we have to look towards discharge. So it broadens my knowledge about the multidisciplinary approach in patient care. Also, then we had to use, like I said, we used an observer that told us, that updated us about the patient behavior through documentation. So that at this juncture, that is the end of my clinical encounter.